Welcome to Real Talk with the Vagina Docs, where we break down the P's of pelvic health: pooping, peeing, pregnancy, postpartum, prolapse, pain, pleasure, and physical activity. I'm Dr. Jocelyn Conley, pelvic floor physical therapist.
And I'm Dr. Jordan, chiropractor and functional medicine expert, and together, we're the Vagina Docs.
Let's dive in. Let's welcome to today's show, Dr. Ritha. Dr. Ritha, thank you so much for coming on Real Talk with the Vagina Docs. Tell us about yourself. What is it that you do? How did you get to doing the work that you do? And anything else you think our listeners would find interesting?
Yes. Well, thank you both so much for having me. I enjoyed our conversation we had before this. And so I'm ready and excited for the conversation that's to come. But yes, my name is Ritha Belizaire. I'm a double board certified general and colorectal surgeon in Houston, Texas. I own my own practice, Houston Community Surgical. I just opened a little less than a year ago. And I became interested in pelvic floor dysfunction when I realized there's kind of a void in the colorectal world. There are certain places that have centers and whatnot that are led by colorectal surgeons and other physician specialists. But in the Houston area, it's somewhat of a void. And a lot of these, disease processes that I can take care of affect women. And I really like taking care of women. And so that kind of got me interested in pelvic floor. And through that process, I've met a bunch of people, but specifically people outside of sort of traditional medicine, including pelvic floor specialists, chiropractors, therapists, all types of, behavioral medicine, all types of different people that kind of work in this multidisciplinary specialty. So that's kind of how I got involved in the pelvic floor aspect of colorectal surgery.
When you were first of all, congratulations on opening your own practice.
Thank you.
That's super exciting and breaking free of the shackles of the system.
Yes, corporate medicine.
Yes. And then a question that I like to ask the physicians that come on the show is like, what kind of education did you guys receive on the pelvic floor, both anatomy and then everything else as it relates to pelvic floor when you were in medical school?
Yeah. So, when it comes to anatomy, we do the whole cadaver dissection. So we learn about the muscles and the function of the pelvic floor. But when it comes to like my residency, so the way it goes, just medical education in general, you do your 4 years of college, 4 years of medical school, and then after that you specialize. So I specialized in general surgery. So I did a 7-year surgical residency program learning how to operate. And then after that, I did a 1-year fellowship specifically in colorectal surgery to specialize in disease processes affecting the large intestine, rectum, anus. Within colorectal surgery is pelvic floor, but unless you're at a center that does a lot of pelvic floor dysfunction, and some of these disease processes we'll talk about a little bit later, but rectal prolapse, fecal incontinence, obstructed defecation, intussusception, rectocele, unless you're somewhere that has like a center that deals with that, which most places do not, then you don't really get many more than 1% to 2% of the patients that you're seeing in all of fellowship are dealing with that. And certainly within general surgery residency, you don't really see much of that at all. So when it comes to education, it's dependent on where you trained, but even within colorectal surgery education, very, very, very little of that is geared towards pelvic floor health. So I don't know the numbers, but very little of your education. So you essentially have to either be somewhere where there's a center or just have an interest in it and do a lot of self-learning to take care of these processes.
I was curious, so like within your training and stuff too, did they ever talk about utilizing pelvic floor physical therapy or modalities like that, like pre-surgery, post-surgery? Because it seems like whenever we talk to like doctors just don't really seem to know about pelvic floor physical therapy. So I'm just curious.
I guess that's a great question. To answer that question, we know that pelvic floor physical therapy exists, but really until recently, till I kind of really got into the pelvic floor world, it was just kind of like, oh yeah, send them to pelvic floor physical therapy. And they could literally be sent into like a garage next door for all I know. Like we just have no idea where they go what they do, like how we know that it's different than like regular orthopedic or stroke physical therapy, but we're like, we don't know what they do. It's just special physical therapy. You know, we know that the muscles are different and that they work differently. There's a thing called biofeedback, but like nobody knows what that truly means.
Okay.
We know like when somebody should go. There's not like a true, there is an algorithm, but like nobody kind of really follows it. It's like, oh, you got fecal incontinence, take some fiber pelvic floor physical therapy, but we don't know what you're doing. We also don't know the exact breadth of things that pelvic floor physical therapists can help with. And I didn't actually know that, again, until I really started looking into it. Like, I have just pelvic pain from either bad endometriosis or, you know, other issues that pelvic floor physical therapy can help with. So yes, we knew about it, but the depth and breadth and the special training that you guys do can help with, not really.
I would say it's the same almost like on our end.
Yeah.
You know what I mean? It's like we don't really know what you do, which is why I'm excited for you to be on and chatting with us and all that. So
you did say, I don't know why I didn't even think of this when we were talking about what we would talk about before. A lot of our patients, or at least in the people I've seen over the years, I've suspected they had bowel endometriosis. And I didn't even bring that up to you, wondering if that's something that you're seeing in your practice. So speaking of that, have you seen much of that in your practice? And if so, let's dive into that first.
Yeah. So we usually only see it once the gynecologists get us involved. There are people who specialize in minimally invasive surgery who have an interest in endometriosis, but it's not its own training, which it almost feels like it's not a benign disease, but it's not a malignant disease. It's like something in between where you almost feel like there should be specialized training in it. But usually the gynecologist will get us involved when they've sort of determine the extent of it and if it's affecting the bowel, or if, let's say, the uterus or the ovary is sort of stuck to the bowel. That's kind of when we'll get involved. But we're never usually the first line because of the origin of endometriosis. Usually a gynecologic origin. But yeah, I mean, I've definitely been involved in either having to, you know, help them take the bowel off of the uterus, or if the endometriosis involves, let's say, the large intestine, small intestine, large intestine, appendix often. And it's really this disease that just sucks everything in. It becomes this really like fibrotic, hard, scarred, painful lesion. And it can sort of like suck any part of the, you know, pelvic organs in there. And if it involves the intestine, then that's when we'll get involved. Sometimes we have to cut out pieces. Sometimes we just have to separate the pieces for them so they can take out the ovaries or the uterus if that's where they're going. But, you know, if somebody just comes to us with pelvic pain, in my mind, that's always something that I want to rule out, but we're never usually like the first line once they've been diagnosed with endometriosis.
When you've done the surgery to help remove the or separate the bowel from whatever's stuck, is it tough? Is it a tough surgery?
Oh yeah. It's like, it's really hard. Sometimes way harder than cancer. The way that it makes, it's like, it's so hard to describe. It's like sticky and scarred at the same time. Sometimes it feels like somebody has just dumped cement into the pelvis. The planes between the organs are indiscernible. And when that's the case, or if somebody has like you can get a bowel obstruction essentially if it's so bad and they're not responding to the medical therapies, you know, that's when you sometimes have to take out the piece of intestine because it's just inseparable. You can't separate it without destroying the piece of intestine. So sometimes it does have to come out. But it's essentially like cement that's also just can be incredibly sticky and just completely distort pelvic anatomy.
I think it's important for people that are listening to hear that. I think sometimes when individuals that have seen us that they've benefited, but like they're still having issues, like understanding, it's really hard to imagine something in your body that you can't see. And so on our end, we try to, on the front end and then throughout the whole process, like get their inflammation down. So we're stopping the endo cycle from continuing.
Yes.
And then, but there are times when like the internal stretching, nothing is working and it's just debilitating. And it's really, when I tell my patients, I'm like, you have to find the right surgeon, don't go to just anyone, go someone who is interdisciplinary going to to add people onto the team because this could actually involve other areas. And part of what we do is we're trying to find people they come in for endometriosis. We look at their history. It's pretty suggestive that it's likely. And so we try to find the driver, if it's not, or before we even say it's endometriosis, what's the driver? What system is kind of out of control that is driving their immune system, and start there. And it is tricky because sometimes their symptoms are more obviously gynecological. Other times they're seeming like their GI tract is angry, and then other times it's urinary, and then
I did an operation on a lady. She's like, I have this really, really painful lump in my C-section scar. And I'm like, I know what that is. My brain just starts thinking, and I'm like, is it worse during your periods? And she's like, actually, yes. And I was like, have you ever been diagnosed with endometriosis? She's like, no. And I was like, have you ever had abnormal periods? And everything was normal. Gynecologically, everything was normal. It was just that she had two C-sections. She had this lump. She just thought it was like a big scar, like part of the scar tissue. She's like, it gets really, really painful and worse with my periods. And I was like, all right, this is what I think it is. Let's take it out. We'll send it for pathology. And sure enough, her pathology came back a few days ago, and it was an endometrioma. And that's the only place she has it, is in her abdominal wall.
Interesting.
And it was painful to her. So people can get it in their lungs. They can get like what's called a pneumothorax, which is where their lung actually kind of pops, and come to find out it happens like on their period, and they have an endometrioma only in their lung. I'm definitely not an expert on endometriosis. I just know that it's not a cancer, but it certainly behaves in a way that affects people's quality of life. And unless you have somebody that's really an expert in endometriosis, that has a high suspicion for it and knows how to operate on it and knows what to look for and all the medical management of it, people go a very long time with this bad pelvic pain or abdominal wall pain. And they're like, it's just a benign thing. Like, don't worry about it.
I feel like we hear lower back pain quite a bit too.
Yeah. And you guys probably hear about this, but like when people have back labor, it's like excruciatingly painful compared to, I don't even want to say normal labor, but like, not having back labor. It's potentially a similar pathway for that. If the endometrioma is located in a certain location, rubbing on like their retroperitoneum, their psoas or something like that, if they have a retroflexed uterus or something like that, I mean, it's possible. But all I know is it causes a lot of problems, mostly pain. And a lot of times it does get ignored because people can't figure out what it is. So yeah, that to me would be the biggest thing. If I had somebody that was suffering with it and nobody was figuring it out, find somebody who this is their like passion project. Their offices tend to be extremely busy because there's not a lot of people who specialize in it. But certainly if you suspect that you have it or that you have a patient or somebody that has something like that, they should find somebody and people travel for this too.
Yeah, they do.
They'll travel to find somebody. And probably it's worthwhile if their life is upended by having this cyclical or constant pain. So yeah, no, it's a huge issue. And as a colorectal surgeon, we do see it quite a bit. It's certainly not at the top of the list of things that specialists take care of unless you are focused on endometriosis.
Before we leave the topic of endometriosis, there is an endometriosis summit every year, and it's like a group of endometriosis experts. And I feel like it's coming around. It's either in the spring or late spring. Maybe I'm completely off, but look up, if you're listening and you're like, this sounds relevant for me, look up Endometriosis Summit. You could attend it virtually or in person. And it's for both professionals and for patients. There's like roundtables for patients to attend. This would be probably something that I would suggest to look into on your end and our end, and maybe attend one time, because I think it would be good.
Yeah, for sure. For sure. Along those lines, there is in Houston, a woman I met through a pelvic, she works at a pelvic floor physical therapy. She's sort of their like front office staff, but she had bad endo, and she started this foundation in Houston that they have like a list of resources, a list of doctors that specialize in it and treat it. And so I think there is a push for, better holistic, multidisciplinary care
Mhm.
for the treatment of endometriosis. Her foundation is called the Endometriosis Foundation of Houston, and you don't have to be in Houston to benefit from the resources they have on there. But I'm glad that it's getting the attention that it needs because people are miserable with it, and
Mhm.
because it's something that affects people with a uterus, a lot of times those things get overlooked. So
Mhm.
I'm glad to see that there's a push for it.
I'll put that in the show notes so people can access that. So you have 2 children of your own, don't you, Rita?
I do. I have a 5-year-old named Amelia, and I have an almost 3-year-old named Rafaela. I actually had them. I'm what they call a single mom by choice. So I used a sperm donor to have my kids. I turned 37 and was sort of over it, trying to date and find somebody. So I just kind of did it on my own. Yes, they're awesome, but I also became very aware of the issues that people that have been pregnant and delivered babies sort of go through as a result of having those 2 kids.
Tell us more about that. Tell us more
Yeah.
about your awareness of and I wanna hear specifically of your pelvic floor, of
Mhm.
awareness of what to do with your core, and if there's not much, that's okay, but then also tell us if you what you did for pushing.
I sometimes don't tell my story because I'm one of those really annoying people. Like I almost like had kids with like a silver spoon. I was very, very lucky. I just want to put that way. I was older when I had my kids. I had my first one at 38, my second one at 41. And I was very, very lucky to get, I didn't have struggles to get pregnant. And then I had like pretty easy pregnancies as it goes. At 41, I was like tired, but like very lucky to have the kind of pregnancies that I did. My first one also is an annoying story because I essentially got put on Pitocin at like 2:30 in the morning and she was out by 9:30 in the morning. So it was like a very quick labor for my first one. And she essentially came out in like 2 pushes. I mean, she must have been shaped like, I tell people like a suppository, I guess more like a bullet, but like her head must have been tiny because so that honestly was like an amazing experience. And the reason I do tell that story is because everybody deserves to have that experience that I had. I had a doula, and I was very anti doula because like I just was like very sciencey, like I don't need any of that and whatever. And when I tell you, even as a doctor who was delivering in a hospital that I worked in, so I knew like nothing about the hospital was scary because I knew everything. I knew the anesthesia. I knew all the things, right? I was friends with my doctor. It is hands down the most vulnerable moment of your life. Like, even if you know all the things and you feel comfortable with the doctor and everything, it's just like there's a moment in time where like things can go very wrong and completely upend your life. And so the fact that I just had a doula that was there to be like, everything's going fine, or sit this way, or put this way, let's put the ball there, let's do, I didn't have to think about being a doctor. I didn't have to really think about anything. She was kind of doing a lot of that for me. She was super helpful for my mom. She was like, please go get some, because my mom was in the room with me. She was like, please go get some coffee. I will call you when it's time to come back. She's just resting now because my mom like didn't want to leave. And anybody that's out there that's kind of like, I don't know, like just all the help that you can get, if you can afford it, get support in that room because it is the most vulnerable time of your life. Even if I was lucky it only lasted a few hours, and the pushing actually only lasted a few minutes. It was 2 pushes and homie came out. She was easy. My second one chose some violence though. She
She was making up for the first one.
she came out, she was all head. She was like no body and all head. So she like I didn't hemorrhage, but I was like a few hundred cc's away from being declared as a hemorrhage. I bled a lot with my second one. Again, I knew the doctor. She was a friend of mine. I had my first one in New York City, my second one in Houston. So they were different doctors, but the labor was longer. I had to have like the balloon in there, which was like super uncomfortable. Like that, if anything makes you aware of your pelvic floor, it's being in labor also while having a balloon in your cervix. Like it just, yeah, the contractions were, and I don't know, I'm a weirdo. Like I had an epidural, but like I wanted to feel the contractions. I don't know. Like there was part of me that wanted to feel that pain. For me, it deepened the experience, and it's different for every woman, and no judgment to anyone who does or does not want that or have that, whatever. But I had an epidural, so it was less intense, but I wanted to feel the pain. But anyway, So my second one, I had the balloon in there and all the things felt like in there, and was pretty heavily feeling the contractions despite the epidural. And because I also didn't like my legs being numb. Like that felt weird to me. And then Homie came out. Her head was like this big. It was like her entire body, and it was like all hair too. And the doctor, when she came out, even the doctor was like, "Wow, she is huge." and, so, and then they like took forever, kind of like suturing things up. The bleeding wouldn't stop, and like I'm just kind of in like la la land, like my baby. You know, I wasn't worried, but she had the doctor. You could see was a little bit worried about it, and everything ended up being fine. But oh my god, that postpartum, holy cow! Like it was almost like my pelvic floor muscles were like, we're going on vacation after that, and we'll be back in a couple months because that was traumatic. I was like peeing on the like I could tell that I had to pee, and so I would go to sit down and I was like, oh, most of it's already come out already. You know, it's like stuff like that. Like it takes some time to recover. I had some pretty significant pain because I had like a decent sized tear from her, and also just like my blood volume had to like come back. I didn't need a transfusion or anything, but like my bone marrow was like kicking out red blood cells, trying to, you know, I was pretty anemic and tired and all of that. So it was rough. I spent the first probably 2 weeks with frozen strawberries, like between my legs. I had to go back to the triage because the pain was so bad from the tear. And I was trying my best to stay out of the hospital because even though I'm a doctor, like I don't want to be in the hospital. So I was like trying my best to stay out, but it was rough. And that again, of all the experiences that are had, is still on the easy end because I didn't have to stay in the hospital for a long time. I went to triage. It was fine. I got sent home, so I didn't have to stay in the hospital. I peed myself for a couple months afterwards, and eventually my pelvic floor came back. But that wasn't easy, but that's still on the easy spectrum compared to what I hear happening to other women. Because my friend, her pubic bone separated. She couldn't walk. She couldn't walk for almost 3 months. She was not allowed to hold her baby and stand. You know, so there's other scenarios where this could have been way worse, but just having that experience, I'm like, yeah, this is something that when it's not working, like we're not okay. It gives that perspective for sure.
I think we should give ourselves more time, especially the healthcare providers. We tend to give our time to everyone else except ourselves. But knowing what you know now in your second experience, if you knew that pelvic floor physical therapy and manual work going into that birth could minimize the degree of tearing, would you have done it?
Oh, 100%. 100%. My first one was a fluke. Like she made me think like having a baby was like, you know, skipping along in a meadow. Like she was so easy. So I didn't think that I needed any of that. I figured the second one would actually be easier. And but yes, absolutely. I would have done that for sure.
So
yes.
That was an indirect way of getting you to say everyone get pelvic PT before actually having the baby.
Yes. I mean, anything you can do to make your recovery from childbirth, better. I was going to say more enjoyable, but like it's hard. It's just really
no matter
hard.
what,
So
it's hard.
Nothing like, enjoyable about the physical recovery. Obviously, the baby's separate, right? But the physical recovery is just really, really hard. Anything you can do. If somebody was like, stand on your head 10 times before you give birth, I've been doing headstands. So like, yes, go do pelvic floor physical therapy. Do all the things that you can do to make it easier. Because if you can recover it, a lot of times postpartum depression is also related to like that first 48, 72 hours of recovery. And if you're sitting there dealing with a tear and severe pelvic pain and all of that, that then determines how like the next year of your life can be too. So anything to make that better, you should do that. So go see a pelvic floor physical therapist before you give birth. If anything, let's say it does help, but let's say it's definitely not going to hurt you. So go and get that help that you need.
For sure.
Yeah.
So speaking of tearing, one of the results or one of the things that we try to work on with our patients so that they don't get, though I definitely have a suspicion it's something that women or vagina owners step into birth already at risk for, is prolapse. And we know that the area that has the most contact pressure from the baby's head is the medial portion of the pubococcygeus of the pelvic floor muscles. So the pelvic floor muscles are collectively called the levator ani, but there's different portions of the collective themselves. And if there is significant damage or tearing, it can affect the connective tissue, or it can affect the muscles, or it can affect all of it, and it can also affect the nerves. So tell us what your role is in management of prolapse. What do you see, Rita? Kind of want to go down the pathway of talking about, like, how do you know when to see a colorectal surgeon, or what's the difference between a urogyn, colorectal?
Sure. Yes. Good question. So just kind of going through the specialists first, as you know, going through the pelvic floor, there's the anterior compartment, which is the bladder, urethra, the urinary system, the middle compartment, which I love that, vagina owners. And vagina owners is the uterus and the vagina, and then the posterior compartment is the rectum anus, right? So essentially, if you kind of divide it in those three, that's kind of how you know what specialist is needed. So bladder, urinary, urologist, uterus and vagina, urogynecologist. You can always start with your gynecologist, and because a lot of times they have some depth of knowledge, especially postpartum, of how to deal with it. And then once it gets outside of their scope, they can send you to a urogynecologist, which is somebody who specializes in the pelvic floor when it comes to the uterus and vagina, cervix and vagina. And then if the back part, the GI tract, is affected, so hemorrhoids, fissures, fistulas, fecal incontinence, something prolapsing out of your bottom that shouldn't be prolapsing out of your bottom, that's where colorectal surgery comes into play. When I see, so usually what happens is those patients will get sent to me essentially after they see their doc for their 6-week, or their midwife for their 6-week postpartum. And if things still aren't like going great, or they feel like they haven't recovered, from that standpoint as well as they should have after 6 weeks. Sometimes I'll see them back again at 3 months, but sometimes that's when they get sent to us. And honestly, I don't mind seeing somebody anywhere in their journey, even if it's like immediately postpartum. I tend to be very conservative when it comes to, because you can't undo surgery. You can always, unless it's cancer, like I don't necessarily push for surgery up front unless I know that's the only way. But for somebody immediately postpartum, I just kind of like support and reassure until about 6 months. And if stuff is still awry, then that's when we talk about more aggressive ways to deal with it. So yeah, even if a person gets sent to me a couple weeks postpartum, I'm happy to see them and reassure them this will get better. Now is not the time. Everything's still swollen. Be with your baby. You don't want to have hemorrhoid surgery 2 weeks after you gave birth, and then come back to me, or we can talk, or telehealth, or whatever, just if they need continued reassurance. But usually it's not until that 6-month mark where I start talking about more aggressive things.
When we were talking earlier, we talked about, and every time I try to say it, I can't say it.
There's too many S's.
Yes.
That's why. Interception. Yes.
Say it again.
Interception.
Oh my gosh.
Interception?
It's like about as complex of a problem as it is a word to say. So
okay, perfect. Let's go off of that. So I'll assess people in first, and I want to go off with what you just said, is when people come to me in their 6 weeks postpartum freaking out about prolapse, want to say that just it's going to be okay. Typically, it is going to be very different in a week, and then in another week, and then in another weekend. Hardly ever is it an emergency. Now, what I want to talk about next, I wanted to say that, and then talk about rectocele. So you mentioned rectal prolapse. I know the urogyns here, patients of mine will see a urogyn for rectocele surgery. So whenever I assess someone, I don't do the same type of I just do a physical exam. I do not do the the K-pop score, or the pop Q. Pop Q. K-pop.
That is something very different.
We always do that score. I need to know that you know your K-pop.
Oh my gosh. Yes, the pop Q. I don't do that, but I could really feel when the rectal wall is just unstable. And it just, when I'm doing the physical exam, whether they're on the table or off the table, I'm just like, okay, you can stop pushing now. It's still coming at my face.
And she makes like all the facial expressions too. And I'm always just like, God, I hope they're not seeing her facial expressions, but she's over there just like
Don't play poker. Yeah.
My favorite is when someone has, no, not my favorite, but when someone has a really significant bladder prolapse and you've only been in the room. So she'll be taking notes. We'll do a co-evaluation and she's taking my notes as I'm doing the exam. One person had a really bad total prolapse, but the bladder was the worst. And any vocal movement she made, it just a balloon out. So
Wow.
significant. But those I really can't keep.
You're so expressive. You can't keep it in.
But
Well, that's a good marker because usually those are the patients where it's like surgery. You probably need surgery and then go back and fix your pelvic floor muscle because they're like too stretched at that point.
My God.
It's like
yes.
So that's a good marker. If you're like making faces, you should have like a Jordan, you should have a score. What her face is. She's
yes.
You're to 5.
My faces say it all. It's a problem. So when I see someone with a significant rectocele, it just like kind of spills out, and it's definitely beyond a grade 2 into a grade 3. The posterior vaginal canal is past 1 centimeter, and it's just keep going.
Yeah.
Is that what you would describe as the I word? The
intussusception?
Yes.
Not necessarily. So I'll say this. You can have a rectal prolapse / intussusception without having a rectocele, and you can have a rectocele without having an intussusception or rectal prolapse. So talking first about what a rectocele is. So between the vagina and the rectum is a septum, and they're separated by that septum. Now that septum is sort of just this fibrous sheet wall between the two. And in somebody that does not have a rectocele, when you go to poop, it just kind of slides right past that septum. If you do have a rectocele, that septum is kind of weak and flimsy, sort of what you were just mentioning. And what happens is it bulges into the back of the vagina. So you have the front part of the rectal wall bulging into the vagina. And what can happen is like poop can get stuck there. And so some people have to, what they call splint, put a finger in their vagina, straighten out, essentially give some integrity to that wall so that the poop can come out of the anus. That is a rectocele. You can have that all by itself without having an intussusception or a prolapse. Now separate, so I'll talk about intussusception prolapse separately. Essentially what an intussusception, a full thickness rectal prolapse is essentially a very long intussusception. What an intussusception is it's a telescoping of the bowel from higher up into the rectal wall. So it's essentially like, I'm trying to think like, this is probably, those like, I don't even know the best way to describe it, but those like, what do they call it? Those like Russian dolls where like one goes into the next or whatever. Yes. Just imagine it going like all the way through. So it's one part of the bowel wall sliding into the other one. Mm-hmm. That is an intussusception, right? So if that lead point, that intussusception comes all the way out of the anus, that is a full thickness rectal prolapse. But there are different scores for those. So if it intussuscepts into itself, but it doesn't come out of the rectum or it doesn't go below like a certain line, mm-hmm. That's a grade 1. If it goes a little bit lower, like into the rectocele, let's say if there's a rectocele, that's a grade 2. A grade 3 is almost out, and grade 4 is all the way out. So when you say intussusception rectal prolapse, it's essentially the same thing. It's just that rectal prolapse is the one that we see where it's all the way out. But it starts with an intussusception. Now, the way that they are often related is that somebody starts with a rectocele. So the rectum is bulging into the vagina. And this is where that lead point is, like at the top of the rectocele. And so the rectum is here and it's kind of just keeps going past that rectocele. And that's where you have to have a lead point for an intussusception. You have to have something where the rectal wall is fixed mm-hmm. so that the rest of it kind of protrudes through. That lead point can be the rectocele. It could be a cancer. I'm not saying that mm-hmm. it's not common that that's what it is. I have a patient that actually just has a lipoma, which is just a benign fatty mass in the wall of her colon. And that thing gets caught and the whole colon just protrudes out of her anus. So she's got a rectal prolapse because of that lead point. So that's sort of the relationship between the two. You can have one without the other, but commonly you will see both. And the way you recommend repairing that depends on the presence of one versus the other versus both of them. Clear as mud.
Yeah.
It's better with pictures. You see, I'm like talking
Sure.
a lot with my hands. It's much better with pictures, and I can get you like a link for that if you want to.
I liked the Russian dolls
Yes,
imagery.
same.
I was thinking of like, you know those.
I think we're maybe
Are you
thinking
thinking
of the
about
same
the thing
things.
growing up as a kid that was like in a plastic?
Yes, and you could
in a
like
plastic like or like, but it was like squishy and
you could
it,
like push
like
it.
you could, and it had like a thing in the center you could stick your fingers in it.
Oh, I'm gonna need a
I'll
picture
send
of
you a
that.
picture of that later.
Yeah. I'm thinking of that too, but I could go with both. The verbiage in medicine is so frustrating because different disciplines use different verbiage at times, and it's just like, ugh. I was thinking of that, but I didn't know it had this ridiculous word, and trying to say that in front of my patients is just impossible. So let's cut to the chase. How do you examine? How do you assess? I'm a definitely go-getter whenever it comes to doing rectal exams because it's like I'm only able to see so much of the pelvic floor when I just do a vaginal exam. And I'll see, I'll find incidental prolapse, like rectal, feel the prolapse. It's like a wall in there.
I just want to point out too, though, like something I definitely want to applaud you on is it just seems like, you know, when people have seen other pelvic floor PTs and you've asked them, like, you're suspicious that there's something going on in that back half of the pelvic floor and they haven't had that examined. So I just like, I'm always impressed that, you know, like it just seems like not everyone goes that way, but you're always like, no, like, let's make sure. So
Absolutely. That is super commendable, and it makes me happy to know that because I can't tell you the number of times I've get sent somebody that has a hemorrhoid and it turns out it's like an anal cancer. I'm like, did anybody look at this or like stick their finger somewhere? Like, and so just the exam is worth like, I mean, that's the key is the exam. So
Well, here the problem is when providers are forced to go into training and they don't want to do it. I've been like obsessed with the front and the back door since 2016 now, even before that. So
you definitely want somebody who's comfortable with it because like it's not a comfortable exam, and if you can sense the provider's also uncomfortable, then it just like raises.
You definitely have to be confident.
So I know my exam process. I do a physical exam and I've done enough now I could feel these are the surgical cases, these are the non-surgical cases. But on your end, what is your exam process? Like, how do you determine whether someone absolutely no brainer, even though pelvic surgery in this case is typically not a medical emergency, but when is it like, here's the deal, you really do need this repaired. Pelvic floor physical therapy can help with lifestyle, but like fixing this, it's just like it's not going to work. Hey listeners, if you're feeling frustrated with your sex life, whether it's due to pain, lack of pleasure, or just feeling disconnected from your body, we want you to know that you are not alone.
That's right. So many people struggle with these issues in silence, but it doesn't have to stay that way. We've created the Healing Intimacy program to help take you from pain to pleasure and restore confidence in your intimate life. In this course, we dive deep into the physical, emotional, and even chemical factors that could be holding you back. And we'll give you the tools to transform your intimate experience. If this resonates with you, head over to our website and join the waitlist. You'll be the first to know when the Healing Intimacy program launches, and you can take the first step toward a sex life that's not just pain-free, but pleasure-filled. Visit www.vaginadocs.com to sign up for the waitlist today. Your pleasure matters, and it's time to reclaim it.
So anybody with a full thickness rectal prolapse, I mean, essentially what ends up happening too is sometimes it becomes so lax, the pelvic floor, and then they get this kind of like patulous anus. And so like, it's just kind of stuck out. Even if you push it back in, it just comes right back out. And so those people's pelvic floors are just stretched out because the rectum is just in the way. Like it cannot function properly because something is in the way, right? So those people, it's not going to get better without a surgery first. And then after that, some people will have fecal incontinence because everything their pudendal nerve has been completely stretched out. The floor has been stretched out. Their sphincters have been stretched out. So that is where you come in with the pelvic floor physical therapy and tighten everything back up, work on strengthening those muscles, and then the incontinence gets better because theirs was an anatomic reason for the pelvic floor to have that dysfunction. So those are slam dunk, surgery is the only way to fix this. Do you have to have surgery? No, absolutely not. But surgery is the only way to fix a full thickness rectal prolapse. When it comes to rectoceles, just the presence of a rectocele, it does not need a repair. If you're asymptomatic, you have rectocele, have fun. Like you don't need surgery. You don't need us. If you have one that's like minimally symptomatic and you're not really wanting surgery, also don't need surgery. For the rectocele, it really depends on the symptoms. If you're like, I have to stick my finger in my vagina and scoop like poop out of my butt, like those are the people that are like, fix this, please. Like I can't live like this anymore. Then yes, those people are like, do all the conservative measures first, do the pelvic floor physical therapy, and see, because sometimes you can get a degree of improvement where you don't have to go through the surgery with pelvic floor physical therapy. But if those have not gotten you to where your symptoms, you feel like they're under control, then let's talk about surgery to fix your rectocele. Now, if somebody has a rectocele and an internal intussusception, physical exam, like you said, you do a rectal exam, you have them bear down. And if you feel essentially their bowel touching the tip of your finger, then you know that there's a degree of intussusception there. And then to see a rectocele, it's pretty easy. Rectal exam, you push up into the back of the vagina. If it's very lax, then you know they have a rectocele. If they're pretty symptomatic from that, like they have what they call obstructed defecation. So they feel that they have to poop, they sit down, they try to poop, they try to have a bowel movement, and then their whole colon is intussuscepting, essentially causing a blockage, and they can't get the stool out. Or incomplete defecation. They're like, some of it came out, but not all of it came out. Those are the people that probably need, even though they don't have a full thickness rectal prolapse, if they have the rectocele and the intussusception and they're that symptomatic, they need the same surgery as somebody that has a full thickness rectal prolapse, which is to essentially, it's called a rectopexy, where you pull up the rectum back into the body and you tack it to their sacrum. And that will, and if you do it with mesh, where you put a mesh between the rectum and the vagina, that fixes both the rectocele and the prolapse. So again, depending on their symptoms, how bad they are, if there is only a rectocele, or if there's only a rectal prolapse, or if there's a combination, that will really determine what operation we recommend. But again, you really want somebody who is interested in this and is willing to sort of be patient, because a lot of times as surgeons, we're like, let me just fix it. Like this is the thing, this is what I can do and I can fix it. A lot of times you just you need to go through all the steps of conservative therapy and then surgery. Other tests that we will often send for, if their symptoms are telling me this sounds like an intussusception, but the exam is maybe equivocal, or maybe I feel something, maybe I don't. There's a couple of imaging studies that we'll get. They're both called defecography. One is x-rays and the other one is an MRI. But essentially what happens is they get this gel put in their rectum, and it's a gel that turns like white on the imaging. It's radio opaque is what they call it. And so then when they take the x-rays, you have them try to have a bowel movement. They're sitting in a chair like in front of you. It's not like a comfortable exam, but it's a lot of information. They're sitting in a chair and they're trying to push that gel out, like have a bowel movement. And then the x-ray can tell us if the wall is kind of intussuscepting inside the rectum, if it's bulging out into a rectocele, and it can tell us the degree of prolapse they're having. An MRI, a similar situation. So those are studies that we often will send people for if we want to really know the degree of prolapse or rectocele.
I want to bring something up.
Yeah.
So my personal experience with any of this.
Wait, I want to hear this.
Has to do with my lizard named Malcolm. I'm wondering now, like, are there colorectal surgeons for lizards or animals, or just in general, or is it just a vet who knows how to and I'm curious too, like, I want to tell you about Malcolm in a second, but is there any point where like someone's, let's say, actual like anus has to be sewed up as part of like the healing process of like, all right, well, they did that for my lizard apparently. So my lizard,
how was he supposed to poop?
Great. I couldn't feed him or water him for 3 days after the surgery. And then he had to go back and have the stitches taken out of his bum. And then
what was that fix? Fecal incontinence?
His butthole was coming out. So I'm guessing, right, what we're, as we're talking about this, but.
Not that I'm against animal rights here, but what in the world was this?
I wish I would have known more so I could have advocated for Malcolm, because it sounds like the surgeon did not do what he was supposed to be doing.
Well, I'll say this. There is a procedure that is essentially of historic relevance in colorectal surgery. It's something called a Tierschweier. Did they use that phrase at all? Tiersch?
No.
A lizard is a reptile. It's not even a
Yeah.
mammal, so
Well, they have an anus though, right? I guess
Yeah,
I don't know
but
anything about reptilian buttholes, but my specialty is mammals, specifically humans. But there is a surgery that used to be done for for prolapse and fecal incontinence called a Tierschweier, Tiersch or SCH. Anyway, essentially what you would do is you would encircle the anus, and it used to be a wire. Eventually it became just like a silk suture, and you just tighten. You don't close it all the way, but you tighten the anus with that wire.
that sounds so
Painful. Yeah,
painful,
that
even if
sounds-
it's in the internal anal sphincter.
My God, I hope Malcolm didn't have
Well, it didn't work. So yeah, we don't do that anymore. But
That's good to know.
that's because they would still prolapse through, and they would be in a lot of pain. Like the recurrence
Yeah.
rate was like 100%. So they stopped doing them. There are other device companies that have tried to make like a magnetic one so that it kind of stretches. Like they make it tight, but it kind of like stretches out. It's almost like this, like this kind of like stretches out. The recurrence rates are so high, and there's better operations to fix that. But that may be what he did. Was get a Tierschweier.
Okay. I mean,
But you should take him out, but I don't know. I'm not.
they took the stitches out, tried to get him to eat and drink. He really wouldn't after that. I don't, it was really sad. I had this lizard for 12 years. He was like little tiny, and then he was like literally like 1.5 feet long. He's the only animal I ever buried. I've had a lot of animals, and he was the only one that I ever buried. But his butthole ended up falling out again, and I was just like, I can't get this lizard another surgery. So
and so he couldn't eat because of that, and that's why.
yeah, like I think he was just like ready to be done. And I remember, oh, it was so sad when I was holding him as he was like, I could tell he was dying, like he was on his last. And I just remember like we had this moment of like making eye contact, and it was just like there was so much love exchange with this little lizard. Anyway,
I'm sorry.
I felt the need to just share the Malcolm story, but
Yeah,
That was a great story.
It can happen to anyone with a colon and a butthole. I mean, it can happen to anyone with an anus. So I'm so sorry,
It's
but
okay.
I don't know.
I feel like
I'm gonna have to ask my vet friends.
we need to be concerned about our French bulldog over here, Billy. I feel like prolapses, rectal prolapses, are definitely a thing in French bulldogs just because of their anatomy.
well,
They just stamp everywhere once they get older.
I'll be consulting Rita about this, even though she has nothing to do with dogs, but she said mammals, so I'll be consulting with her.
Yeah, I'll bring up mammals. You are right.
So, not to go back to boring questions, but one thing I have a question about is how do you avoid infection? I think the thing that freaks me out about any sort of prolapse surgery is if you have to poop and you had a rectocele or rectal prolapse surgery, what's the plan? Like,
Yeah, and you have to poop?
Yeah.
Then you gotta poop.
Ye-
Yeah. No, we want you to poop. We want you to poop. But usually what we'll do after these surgeries is we'll actually make the stool like looser because we don't want having to pass like hard stools. So these patients will get put on fiber and like twice a day Miralax, sometimes even 3 times a day, because we want that really just kind of scar in.
Okay.
And it depends on the approach that we use. There's a couple different ways you can approach rectal prolapse surgery, depending on the patient's medical history. But no, we want you to poop. We want you to poop. And if you like recur immediately, then it wasn't a good repair. You know what I mean? So even passing hard stool, if you recur immediately, then there was probably something wrong with the repair. But as far as an infection goes, when you do the repair, like I like to do them robotically, so meaning small incisions on the abdominal wall, you don't have incisions down below. So you can poop to your heart's content, and that you're not at higher risk of infection because you don't have incisions down there anyway. Even if you do a perineal repair, which in older folks or somebody that's like on blood thinners can't tolerate general anesthesia or abdominal insufflation where we blow up the belly to do minimally invasive surgery, sometimes they have to have a perineal repair, so we fix it from the anal side. Even those people, the incision is way up on the inside, and so they're not at any more risk than at all for infection. But I can see where that concern would lie, but their risk is pretty low.
I have a question too, because I've heard this when, we've talked to, trying to remember that clinic that you had done, but basically a woman came up and she was talking about how she'd had, it sounded like multiple repairs. And it was at the point where basically like she was still having.
She had a fistula.
Yes. So what do you do in that case when basically the surgeon's like the tissue's too flimsy, too like weak for us to even, repair this?
Well, for fistula, complex fistulas can be pretty tough. Depending, and it also depends on why you have the fistula. But if you had multiple repairs, the subsequent repairs actually are at higher risk of failing. And there are actually studies going on right now looking at PRP combined with other materials to put in as plug to help these people with these complex fistulas heal. In somebody that's had multiple repairs that is still pretty symptomatic and whatnot, I would actually offer that person fecal diversion with an ostomy, not permanent. And then
what does fecal diversion involve?
So an ostomy bag. So meaning
Okay.
you bring the intestine to the abdominal wall, they poop into a bag. So you're diverting the flow of stool away from the anus into the bag. And obviously that requires a lengthy conversation, but I would offer them a diversion, an ostomy, and then put drains in the anus to just get everything to dry up. The worst thing you can do is try to fix a fistula when there's still really active inflammation going on. And the best way to sort of calm that down is to avoid anything passing through there, like stool. So divert them, put drains in where you need to, let everything kind of dry up and get the integrity of the tissue to improve. And then they probably need somebody that actually does complex fistula. Like there are people that specialize in complex fistula repairs to, take a look and see what needs to, what the fistula is affecting, because it can affect the sphincter muscle. It can affect the levator muscle. It can take a tortuous course. It can have many different branches. And so you would really want somebody to once she is diverted and kind of the fistula, maybe the inflammation goes down, I would get an MRI specifically looking at the path of these fistulas. So just for anyone listening, a fistula is an abnormal connection between the inside of the anus and the outside, like the gluteus or the perianal area, the tissue outside the anus. And it manifests often as an abscess on the gluteal tissue because there's an opening on the inside of the rectum or the anus, and the bacteria from inside our GI tract kind of burrows its way through the tissue and creates a big abscess. So then you end up with an external opening and an internal opening and a tunnel between the two. And a complex fistula is one that has multiple branches. It's essentially these kind of like groundhog tunnels potentially, in the tissue. So if I were her, what I would recommend to her is diversion first. Let everything calm down and then go see somebody who specializes in difficult fistula repairs. They would probably need an MRI to delineate the anatomy of those fistulas and then determine which surgery would be best for them. Sometimes, honestly, people become so miserable with the fistulas. They're like, just give me the ostomy. I don't need them fixed anymore. And they're happy. They actually live a happier life because they can control what's going on from the bag. So that's certainly not a first resort as an ostomy, but somebody that's had multiple repairs and that the repairs keep failing, that, sometimes we do kind of go to those extremes to get things to heal.
Is anyone ever concerned about there being connective tissue, diseases or autoimmune stuff going on for these kind of people who, why aren't they healing? Why is the tissue just so weak too?
Yeah. And sometimes it's just bad luck. You get a bad fistula and it's just bad luck sometimes. When somebody has fistulas that keep popping up and they're not healing, you have to rule out other reasons why, like you said, one of which is Crohn's disease. And to diagnose Crohn's disease, you get a series of blood tests. Oftentimes you'll get a colonoscopy with biopsies. And the way these things tend to heal is actually with medication to treat the Crohn's disease rather than surgery. But it could also be an STD. It could be syphilis. It could be HIV. It could be tuberculosis. It could be cancer. It could be cancer. There's a number of reasons that it could be, or it could, like I said, just be bad luck. So in somebody that's not healing their fistula repairs, you definitely want to rule out any kind of systemic problem that they may be having as to why the tissue isn't healing. When it comes, you brought up connective tissue disorders, which is really important to think about in somebody that's, let's say, had rectal prolapse and they failed multiple repairs. You have to, sometimes connective tissue disorders, they can get, really a lot of laxity in their soft tissue and their joints and whatnot. And that affects them when they do have rectal prolapse too. So certainly anyone that's had these repairs and they're not holding, you definitely have to rule out some kind of systemic disorder.
And then what do you do from there? Like how, if they've...
It kind of depends. So like if it is something like Crohn's disease for anal fistula, you treat the Crohn's disease. And a lot of times, sometimes people will live with a drain permanently, but they never end up with like the bad abscesses that keep landing them in the hospital. So they're fine with just like a little rubber band drain, and they stay on the medication to keep everything dry. Sometimes you can, in people with very well controlled Crohn's disease, you can take out that drain and see if that will dry up on its own. If it's something like cancer or HIV, you just treat the underlying disease. So the fistula or fissure could be a symptom of the disease. So you're essentially treating it like a symptom rather than I need to fix this fissure. If you're not treating the underlying disease, it's just going to come back. So it really depends on what it is. But those with connective tissue disorders and the prolapse, they can sometimes have a pretty hard time with getting that treated. And a lot of the times, those are the people that we will recommend strongly putting a mesh in to fix their rectal prolapse, because it's a little bit more of a durable repair.
I was just going to ask you next. What are your thoughts on mesh?
Yeah. So I like using mesh, but it's not a good option for everyone. So in somebody that's got a full thickness rectal prolapse, they don't have like any underlying like diverticulitis, which is like inflammation, infection of the large intestine where the mesh could potentially get infected. And then also from a psychological standpoint, if you know that somebody's just going to be thinking about the mesh all the time after you put it in, they are not the right person to put a mesh in. Like if you have somebody that's like obsessive and they're like, I think it's the mesh, and they're never going to stop thinking of it, that's not the right person. You just use sutures on those folks. And then there are people that just don't want it because they're just too afraid of it. But it does lead to a more durable repair. The risk of recurrence is lower. The mesh is hidden away from the rest of the intestine. So it's covered over with peritoneum. So it is hidden away. But anytime you put a mesh in, there's always a risk of mesh erosion, either into the vagina or in the rectum. It usually, if it's going to happen, will happen more, erode into the vagina. If it's going to happen, if it's not done correctly, you can get some pain from the inflammation that the mesh causes. And then there's different types of mesh. You can use a permanent mesh that never dissolves. You can use a semi-permanent mesh where most of the mesh dissolves, and then you can use a biologic mesh where eventually, and it's usually over years, once sort of the rectum is kind of scarred in up on the sacrum, will dissolve. And that the biologic mesh tends to have a lower risk of infection. But honestly, in the data, the risk of infection with a mesh is so low that the data doesn't really parse out between, or the risk of infection is essentially the same with synthetic or the permanent mesh and the biologic, because the risk is so low, they don't have enough numbers to really kind of parse out the infection risk between the two. But when done correctly, and by somebody who does these frequently, the risks are pretty low. The stories that you always hear, the stories about, people that have the problems with mesh, and definitely not trivializing anyone's story at all, because who cares about the statistics when you're the one that has the complication, right? So it's not for everyone, but in a good candidate, I think it is the best option.
We tell our patients all the time, like if someone needs a surgery as significant as a reconstruction of some sort, vaginally, rectally, whatever it is, please get your health. And this isn't always possible, but like manage your stresses, change your diet, start changing your life so you're not so inflamed. Like if you're in an inflamed state and you go into surgery, I think you have a lot to work up against. Like surgery is a major
trauma to the
trauma.
body. I mean,
And so I think then also, this is where I'd say, depending on where you go, I've had a lot of complaints of my patients saying that their surgeon didn't give them any sort of aftercare suggestions.
Yeah.
But there's also that they did, but it just went in one ear and out the other because
Yeah.
you were thinking about 1,000 things at once.
Well, and I'd also like to say that people need to take responsibility for their health too. You know what I mean? Like, even like as a patient, like as someone coming in, like I think the web is great because now you can ask a lot more questions, you know, just because you have a little bit more knowledge. And I think though, like it's not always just on the doctors, if I'm like too, you know what I mean? Like people also I think need to take responsibility for their health also. I mean, everyone can do a better job on both ends, I guess, but ultimately like
you can't be the only one that cares about your patient's health.
No, they have to care.
No, you're right.
A patient of mine that the other day that I'm like, I think if your quality of life is that impacted, like definitely consider the surgery. And the idea of mesh or not, I mean, me personally, I have a prolapse, never had, or I have a cystocele, never had kids. I've just had, my health was not the greatest growing up, very high impact training, weightlifting, and not an optimal mechanics either. So bearing down all the time, I would brag to my friends that I could poop. Literally, I'm the world's fastest pooper. And it was because I would bear down and not the way that my pelvic floor was relaxing.
Right. You're just like exploding through your pelvic floor.
I love that was something you were just like bragging about. I
would brag and say I could be in the Guinness Book of World Records, the fastest pooper. So all that to say, like I love weightlifting. As much as I don't like CrossFit for a lot of people in the world, I love it for myself. And so if ultimately I need a prolapse repair, I think I would consider mesh because of my lifestyle. I would consider it. And even though we had this discussion and we've heard the horror stories of like the mesh, just like you can't remove it because it's so embedded in the tissue. I think the great candidates who are going to respect their body, respect the surgery, it's stronger.
Yeah. I mean, you're not alone. There are colorectal surgeons who don't want to do this operation because the thought of like mesh on the rectum, it's like they literally like have nightmares over it. I don't use a permanent mesh. I use the one that can dissolve, but it dissolves over a very, very long period of time. But there are some that do use a permanent mesh, and you know we have to go by data, and the data shows that it is safe. But yeah, as somebody who does the surgery, it's not without like a little bit of like cringiness that you think about like a permanent mesh stuck onto a rectum. In fact, one of my partners is like, I will never do that surgery and I will send you all of those surgeries. He was like, because my anus contracts when I think about mesh on the rectum. So he's, you know what I mean? You're not alone in having that feeling about, or patients that feel worried about it. You know, it's, you know, our job as surgeons and health providers, we have to give them all of the information about the risks and the benefits, why we think they're a good candidate, what our recommendation would be. But like ultimately it's shared decision making. And so if you're like, I would rather accept a little bit higher recurrence rate to not have mesh, then that's what we do. And if any surgeon is like, well, then I'm not doing your surgery, then maybe that's not the right person for you. You know what I mean? So shared decision making should always be something that is employed. And, you know, I'll push a little bit more if it's something like a cancer where I'm like, please just, you know, even go to another surgeon. Like I don't have to be the one to do it. Please go talk to somebody else to get a second opinion about this. You know, if I really feel strongly about a treatment option. But again, I will never force somebody into a surgery ever.
I think for people listening, the important thing is do your homework before, do the work before. See us first.
Yeah.
Or people like us first to get you prepared so that you know what you're going into after. And then typically things will work out. There is a topic. Something that I want to talk to you about before we wrap things up is a more serious topic. And I think a lot of us, and even myself and Jordan, we need to listen to this as well. Why is blood in the in stool so important to pay attention to and not just brush off?
Yeah, that's a good question. And I see a lot of people that come because of the fear of blood in the stool. So anytime there's blood in the stool or you have changes in the color of your stool, it becomes really dark. You know, it's because something inside is bleeding, right? And it could be nothing. It could just be hemorrhoidal bleeding, which often just goes away and it doesn't turn into a cancer. Or it could be something worse, like a cancer. And so it's not, I guess to say, all that to say, it's not normal to have blood in your stool. It's never normal to have blood in your stool. And there's a spectrum of reasons that it can happen. And so if you're having blood in your stool, even if it probably is from a hemorrhoid and it's benign, just go get it checked out so that somebody can tell you that it's benign. And if you're anywhere near the age of 45, that's the screening age now for colorectal cancer. It used to be 50. And because we're seeing it in much younger patients now, even as young as like 20, we're seeing colorectal cancers, and they tend to be more aggressive in the younger folks. And it's not to scare anybody. It's just to say, if something's abnormal with your bowel habits, bleeding, change in like the caliber of the stool, constipation and bloating, whatever, those are not really normal. And just go get it checked out. Let somebody do a workup and tell you that it's not normal. Or tell you that it's abnormal, but for a benign reason. But yeah, anything that, your stool tells you a lot about your overall health. So if you find blood, just go get it checked out. You can go to your primary doctor. You start with your primary doctor, start with a gastroenterologist, colorectal surgeon. We all can manage blood in the stool and do the workup for that. But that is a really good point.
Rita, do you look at your poop after you poop?
Not really. So I guess sometimes, but not really. I look at my kids all the time. No, because I guess this doesn't really have much to do with the question, but I'm a big proponent of, number one, the squatty potty or a box of any kind to lift up your legs, to relax your pelvis, get your knees up above your belly button to relax the pelvic floor to help you have faster bowel movements. And number two, a bidet.
Oh,
like
yeah.
the tushy.
Yeah.
Yeah. Like those
We
things
make it
are,
Those are
yeah.
awesome.
Yes, and they're not super expensive.
No, like $50, $50 to $75 for a decent one.
Yeah, they're easy to put on the toilet, but like I often just will tell people, like, because often people will use, let's say, like baby wipes, and then they'll get like a contact dermatitis, and they'll just have like a bunch of itching, and they think the itching is from hygiene, so they'll use more and more and more and more baby wipes, and then suddenly they're in my office, and I'm like, but I use a whole thing of baby wipes, and I'm like, that's why, because just use a bidet. It's water, some toilet paper, and the other thing too, it's like this was somebody, I can't remember who said this, but one of my friends was like, if you step in dog poop on the sidewalk, are you going to go get like dry toilet paper to wipe it off? Or are you going to get like a power hose to get that off of you? And like, we don't even have to answer because we know the answer to that. So it's,
but a good.
Put yourself a power hose for your bottom.
That was a good tidbit.
Yeah.
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 Great.
So do you push your poop out? Or wait, I meant to ask, do you look at your poop? And then I wanted to ask, do you push your poop out?
I look at all my poops.
Not only look, we like stick our face in the toilet and investigate what's inside.
I just want to
I'm
know.
not there yet. Yeah.
How I'm doing day to day. So far I'm good right now.
Can we share the story?
Which one?
One day you were like, there's a worm in here. We did share this with you, how we were looking at the toilet and there was a worm in there.
Wow.
What are you talking about? My worms or your worms?
I have not ever had worms.
Yeah. No, a few months ago, I had definitely had two very distinctable parasites that were in my stool.
Yes.
And they were, what?
Pin?
No.
Worms?
White.
No.
About,
I don't know.
I don't know, 6 inches.
I don't know my worms. I just know they're not supposed to be there.
Not supposed to be there. We eat way too much sushi.
They're so much more common, Rita, than most people.
Probably.
Like the amount of like people I work with who have parasites, and it may not show up on a stool test, but then I might be helping them herbally and they're coming out. It's very interesting.
So the verdict here is everyone should be looking at their poop.
Your poop definitely tells you a lot.
It tells you a lot.
It tells you a lot.
I love knowing.
And don't ignore it when it's not like normal poop. Don't ignore it.
Yeah. And when it is normal, isn't it so satisfying just to have a regular like solid?
Yes.
We like cheer each other on for our.
You get like a little bit of like an endorphin rush.
Yes.
Actually.
Yes.
It's like a little on your toes, and
for some reason it feels like you're just doing a marathon or a strongman or something. I don't know.
Yeah. You want a prize? Yes.
And the last tidbit I wanted to give to people who are listening is, and it was in my head, of course, and that's when I asked, do you push your poop out? So I learned the lesson the hard way, and I pushed my poop out when I didn't need to for one of the first 20 years of my life, and now I did have issues. And I don't think people like when people push, like I'd say either 50 to 60% whenever I'm doing my exam, they have co-contraction in their pelvic floor. It tightens. And so I say it's like they're pushing against a closing door versus there's a proper push where the pelvic floor elongates and softens. And then there's the improper push. And the improper push, I'm thinking like the movie scenes in when women are delivering babies. Like that's not the proper push.
Well, and let's say too, like when you test someone how they push, what percentage of like the people that we've seen come through, like who pushes correctly and who doesn't?
I'd say it depends on the season, but upwards of 60% do it wrong.
Yeah. No, I think so because you're pushing. Like I don't even know how to describe it, but you can feel when it's like a normal push, when it's like your belly comes out and like everything relaxed.
Yeah.
Versus like you're contracting your muscles to push, because then everything contracts and it's never gonna work. Yeah. But you can get it out, but you need the everything relax Valsalva kind of push.
We have like a million other questions for you, but we know that it's been a long time now. So before we ask all of our guests to answer or talk about if you could give someone advice that would empower their pelvic health, what would it be?
Yeah, I mean, I think you kind of I think you touched on it. Anything that looks abnormal in your stool, get it checked out. Just start somewhere. Start with your primary care, and then they'll get you to the right place. Number two, you don't have to live in pain if you've got pelvic floor pain. You don't have to live with shame. Like, I've had a patient say, oh, my mom always just told me, like, after you have kids, like hemorrhoids are just normal. You just live with it. And they're living with these like big painful hemorrhoids. I'm like, you don't actually have to live with that. There are people that treat it. If you've got a rectal prolapse or fecal incontinence, like people aren't leaving their homes or they're wearing diapers, you don't have to live. They're very treatable illnesses. So like, if something feels different or weird or awkward or whatever, you don't have to live with it. Something that feels abnormal, don't let anybody tell you like, oh, that's just normal. Like just find the next person that can potentially treat you. And there are pelvic floor specialists, colorectal surgeons, urogynecologists, urologists, pelvic floor physical therapists. There's a whole group of people that can treat it. So don't ever just take somebody's, oh, that's normal as the end of the story.
So Rita, we talked about this before, and I don't want to put you on the spot on the show. So if I have to edit it out, let me know. But are you going to be available on the Vagina Docs team of talking to people virtually?
Yeah. So
and
after
in person,
I had that
obviously, but
yeah. So anybody in Texas, I'm licensed in Texas, so I can treat anybody in person or telehealth, where it's like health related insurance, whatever, in Texas as their doctor. But after talking to you guys and hearing that there are a lot of people that just kind of don't know how to navigate the medical system, it has been brought to my attention that like just a little bit of coaching of like, who do you need to go see, or like, is this an abnormal thing? Like, I can't give you medical advice, but I can give guidance. And so I'm in the process of setting that up. I have a handout that I'm going to put on my website that's just like kind of a primer of like, who do I see and what are the organs in there, from the medical standpoint, like physician standpoint and like imaging and all that kind of stuff. So they can get that on my website. But yeah, that's sort of like up and coming, like to be determined when that happens. But now that I know that there's a need for that, for us, it feels like basic knowledge, but for somebody going through it, it truly is not basic knowledge. And so I would love to kind of guide anybody just to getting to the right place so they can stop going somewhere and saying that somebody else needs them. They can like maybe try to get to the correct place a little bit faster.
Sweet. So we'll need your information so that we can share the word. And I know that I've certainly had people in the past that needed exactly this. I would consider medical coaching or medical consultants. Yeah. Basically, you have the knowledge that like someone could Google this and they are just given so much information. It's just a laser focused.
And them trying to figure this out on their own without having the knowledge. Like it can be really scary sometimes when it doesn't also need to be, like.
Right.
So.
Exactly.
Yes. Exactly. And it's like drinking from a fire hydrant when you see all the stuff that's on Google.
Mm-hmm. Are you on social media?
I am, yes. So my TikTok and Instagram are my name, Ritha Belizaire, MD. And then I have a Facebook group called The Bottom Line, actually, that it's still sort of in the infancy of it. It's not terribly active, but I just want people to go there to feel supported, just get information about, pelvic floor, colorectal related pelvic floor health. And then I have my business Facebook page, Houston Community Surgical is the name of my practice. That's the website, HoustonCommunitySurgical.com. They can kind of get more information about me on there as well.
Is the bottom line a play on words?
Oh, yes, it is. Yes,
That's
Loved
awesome.
it.
it is.
Yes. I love that too. I want to be part of the group. Can we join?
Awesome. All right. Yes, of course. If you're on Facebook, come on in. I think it's searchable. So
Okay,
yeah,
cool.
you can
And we'll
absolutely
need
come
all
in. Yeah.
those links. So all the links will be in the show notes. Well, thank
Okay.
you so much,
Yes, thank you.
Dr. Ritha,
Thank
for
you.
coming
This
on
has
our
been really
show. I'm still waiting for you to say, I'm moving to Phoenix. So if that ever is the case,
You know what? If Houston keeps having these like freezes, I probably will find my way over to Arizona.
we would
So
love
let's-
to have you here. But in the meantime, if you don't, then we'd love to have you back on the show sometime in the future to talk about things like fissures, hemorrhoids, cancer,
All things
all
bottom.
things.
You guys are awesome. This has been so fun. Thank you so much for having me on.
Thank you.